Opinions, options, answers. Voice America Health and Wellness.
Welcome to Psychiatry, Ask the Expert, hosted by Dr. Neil Kaye. All comments, views, and opinions expressed are solely those of the host, guests, and callers. Dr. Kaye will not diagnose or treat callers. The information provided is informational in nature. In the next hour, Dr. Kaye explores the inner workings of the brain and mind. Grab a pen and paper and sit back. Here is your host, Dr. Neil Kaye.
Good evening. Welcome to our show tonight. I'm Dr. Neil Kaye, and my co-host Jay and I want to welcome you all to our show today.
Hello, everybody, and I hope you're all having a warm evening at home. Well, it's certainly cold here in Wilmington, Delaware.
Great to be with everybody. Now, each week on Psychiatry Ask the Expert, we focus on a specific topic in psychiatry. We talk about the disease or illness itself, the common symptoms and presentation of the illness, and, of course, treatment options with a focus on psychopharmacology, the medication treatments. We talk about potential risks and benefits of treatments, side effects, dosing, when and how to use the best medications, and we try to keep the evidence for these medications from a science perspective in mind. Tonight we're very honored to have Dr. Glenn Treisman with us. Dr. Treisman is an associate professor in the Department of Psychiatry and Behavioral Sciences at the Johns Hopkins University School of Medicine in Baltimore, Maryland. And tonight we're going to be discussing bipolar disorder and attention deficit disorder and how to tell them apart. Glenn, welcome, and say hello to our guests tonight, if you would.
Thank you, Neil. I'm glad to be on your show, and I feel privileged to be able to be part of this. Thank you for inviting me.
Well, great. We're delighted to have you. Listeners, you're invited to call in at any time. Remember the number 866-369-3742.
And now we're going to start with our lead-in section on a radar screen. This, as you know, is current topics that we've come across since last week's show, items of interest in the lay journals or in professional journals that tie into mental health and mental illness. Neil, what do you have?
Actually, I only have one this week to bring up that I thought was real relevant for Dr. Treisman. There was another report out on MRIs, magnetic resonant imaging. We talked about this last week in terms of using new imaging technology for diagnosing mental illness. And there's a new report out suggesting that functional MRI might actually be able to distinguish between unipolar depression, major depressive disorder, and bipolar depression, and that's an important distinction, and we'll see if Dr. Treisman has any comments on that when we come back to him. What's been on your radar screen this week, Jay?
Well, Neil, I've spent some time catching up on articles in the lay journals, and actually I'm looking at the January 16th issue of Time magazine, an article that I also would like to hear something from Dr. Treisman on, entitled, "Help, I've Lost My Focus." And the essential topic of this article is how people today in our workplace have become essentially indoctrinated, if not accustomed to multitasking, and many people are appearing in psychiatry offices and in primary care offices with symptoms very much like, as they describe, attention deficit disorder. And so the whole article focuses on really how much our society and our workplace is based on multitasking, whether that's good or bad in terms of work productivity. So that's something we can ask Dr. Treisman about in a few minutes.
Great. Jay, I think it's a good article, very relevant, and really a perfect lead-in for Dr. Treisman. What we're talking about is that everybody today comes into doctors' offices and complains of problems with attention, and of course the doctors are all trying to figure out what this is. Is it ADD? Is it something else? So, Glenn, to get started, can I get you to try to define or describe bipolar disorder and attention deficit disorder for the audience so they have some sense of the difference and what we're really going to be talking about?
Absolutely. I'd be glad to do that. Bipolar disorder is one of the psychiatric problems that's most well characterized. We've known about it for thousands of years, and the classic literature talks about Kraepelin's work distinguishing between schizophrenia and bipolar disorder, and he characterized bipolar disorder as a relapsing disorder where people got well in between episodes, which is a very important characteristic of the condition. It's called bipolar disorder, and as opposed to unipolar depression or major depression, because patients get both episodes of low mood or diminished energy or decreased pleasure out of things, and episodes of elevated mood, increased energy, and perhaps increased pleasure out of things. And that's why it's called bipolar. The other name for the same condition is manic depressive illness or manic depressive insanity. And bipolar disorder, in its classic form, usually comes on equally often in men and women in the late teens to 20s. And people will usually have manic episodes earlier in life and depressive episodes later in life, although women tend to have more depressive episodes than men, and men tend to have more irritable mania than women. But overall, the depression is more common in women. Bipolar disorder is about equally common in both sexes. And the incidence of true bipolar type 1 disorder, or classic bipolar, or manic depressive illness, is about 1% of people everywhere. So it's 1 in 100 people has it. It's a very common illness, and it's a very severe illness. A lot of the people who you see who are chronically mentally ill, wandering around the city and homeless, have untreated bipolar disorder they've had for years, and people do deteriorate if they have untreated bipolar disorder for long periods of time. But it is an illness that usually comes and goes in episodes, and people are usually well from it for periods of time and then get sick and then get well again. And the episodes, how long they last and other things, can be variable from person to person. But if you look at the data, people tend to have more frequent episodes as they get older with less well time in between and more severe episodes. When they're young, the episodes tend to be a little further apart, and they tend to be more well in between.
So let me summarize quickly. So bipolar disorder, a cyclical disorder, episodes of depression, periods of normal mood, periods of elevated mood to various heights, and overall good functioning in between, chronic illness, but actually good prognosis with treatment that we're going to be talking about. Absolutely.
Now, you mentioned a very interesting thing. You mentioned getting well in between. There's a very interesting thing about bipolar disorder that makes it, this is the part where it kind of blends over into things like ADHD and others, in chronic mental illness. People will be symptom-free, but not completely well for periods of time. That is, after an episode, their symptoms will go away, they won't have a mood change, but they'll still be disorganized and have trouble functioning, even for months after an episode. And so you really have to treat people aggressively and keep them well for their functioning to be normal. Because if they're having frequent episodes, even if they're mild frequent episodes, they're not all the way well in between, even though they don't have symptoms. And that's a very important element of bipolar disorder.
All right. Give us a couple minutes and tell us about ADHD or ADD and classic symptoms for that to separate the two.
Right. Well, attention deficit disorder was described much more recently. This is a condition that people have been talking about pretty much for 100 years, not 1,000 years. But what people noticed was there are kids who have, and it was first described in kids, who have pervasive difficulty with attention and distractibility. And those kids were felt initially to have some kind of brain injury. So the disorder has been called a number of different things, but one of them is minimal brain dysfunction. You'd see kids with good IQs often. They were often smart, but they couldn't attend to task, and they couldn't complete tasks. They were very distractible, class clowns, cut-ups. And there's a lot of difficulty with redirecting their behavior. Boys have this disorder probably more often than girls, but it's hard to tell because boys often have hyperactivity. That's what the H in ADHD is, hyperactivity, whereas girls may have the attentional deficit but not have the hyperactivity. So girls can have distractibility and be thought of as not very bright when actually they're bright, but they have difficulties with attention. So they're more often missed than boys who have ADD. And you can kind of tell these kids when you bring them into your office because they really can't pay attention to things. They have trouble listening to even a very short paragraph-length story. They have trouble watching cartoons on television because their attention wanders. And if they watch a cartoon, they often can't tell you the plot because their attention has wandered. And they'll understand all kinds of things about the story, but they won't be able to follow the storyline because of their distraction. And these kids range from being mildly impaired to profoundly impaired by this condition. But the other problem is, and by the way, this is not a waxing and waning condition like bipolar illness. So in childhood, sometimes bipolar illness is mistaken for ADD, but you can usually tell when you hear a history of a person, a kid does really well for a year in school, then has a bad 3 months, and then does really well again for a year in school. You're thinking more along the lines of a mood disorder. But if a kid always has the same problem, then you're thinking more along the lines of a behavior problem or ADD. Now,
that's helpful. What we're going to do is pick up after the break with how psychiatrists actually go about diagnosing ADD versus bipolar. What are some of the key symptoms that might separate them? I mentioned brain scans. Are these helpful? Is there a blood test? What about the written tests and things like that? So we'll go to break and pick up with diagnosis after the break. You're listening to Psychiatry Ask the Expert with Dr. Kaye and Dr. Treisman.
Real Life Solutions. Voice America Health and Wellness.
To perform at your maximum potential, you need to have all aspects of your life working properly. On Mind, Brain, and Body, Dr. Michael John Kell will bring you honest, open discussions concerning your physical, mental, and financial health. If you're ready to find purpose and meaning in your life, tune in to Mind, Brain, and Body every Friday at 8 a.m. Pacific. Mind, Brain, and Body on Voice America Health and Wellness. Radio dedicated to your health, wealth, wisdom, and purpose.
Videos de aprendizaje de inglés. Máxima calidad.
Nunca escucharás a alguien vendiendo educación en la calle, pero con programas familiares gratuitos sí puedes obtener la educación que necesitas. Llame al 1-877-326-5481 para información sobre programas gratuitos de educación familiar.
Mira, vengan aquí. Obtengo un mejor vocabulario en inglés garantizado.
El primer paso a una vida mejor. Un mensaje del National Center for Family Literacy y el Ad Council.
Achieve exceptional levels of health and fitness through integrating the very best in fitness, nutrition, and healing. Tune into Total Fitness with fitness, nutrition, and healing coaches Catherine Kerrigan and James Williams. Each week, get inspired to exercise, eat and rest in harmony with your body's needs, and take advantage of effective natural healing methods with in-depth cutting-edge information and advice. Get fit, get healthy, get motivated, and get real with Total Fitness, broadcasting every Friday at 7 a.m. on Voice America Health and Wellness.
Parents, did you know that high school dropouts make 42% less than graduates? Someone will have to make up that difference, and chances are that will be you. That means paying 42% of their groceries.
Ooh, more candy.
42% of their dentist bills.
No more candy.
Even 42% of their therapy sessions.
It's all my dad's fault.
Save your money. Encourage your kids to stay in school. For help and advice, call 877-FORAKID. A message from the U.S. Army and the Ad Council.
Are you tired of being tired? Are you sick of sitting around while life passes you by? You can get back on track by tuning in to Voice America Health and Wellness every Monday at 12 p.m. Pacific Time for Attracting Abundance, the Energy of Success with Carol Look. Attracting Abundance is the program that empowers you to finally break through your limiting beliefs and blocks and shows you how to succeed in all areas of your life, from improved financial abundance, health and weight problems, as well as your relationships. Don't wait another week to be joyful. Listen to Attracting Abundance, the Energy of Success with Carol Look this Monday at 12 p.m. Pacific Time right here on Voice America Health and Wellness.
A fresh look at today's health. Voice America Health and Wellness.
Welcome back to Psychiatry Ask the Expert. If you have a question or comment, dial toll-free at 1-866-369-3742. Now back to the show. Here's Dr. Kaye.
Welcome back to Psychiatry Ask the Expert. I'm Dr. Kaye. We have Dr. Glenn Treisman as our guest tonight. And, Jay, you had a question you wanted to ask Dr. Treisman to address right up.
Yeah, I did. How are you, Glenn?
I'm great.
Listen, before we went to the break, you were describing attention deficit disorder, and previous to that, you'd gone through a description of bipolar disorder. And with bipolar disorder, you gave a kind of a timeline, late teens or late teens, early 20s is kind of the onset for diagnosable bipolar disorder. And you described attention deficit disorder, at least the way I understood it, as occurring significantly earlier than that. So is that kind of the way it presents clinically, that kids
most of us think these kids have this from birth, that it's a problem that they always have, but that you can't diagnose it until their attention span becomes naturally long enough for you to see the deficit or the difficulty.
Okay.
And so it tends to be something you diagnose fairly early on. The more severe it is, the easier it is to diagnose. So I'll see kids even 3 and 4 years old, and I'll say, that kid's going to have ADD, I know it. And sure enough, a couple of years later, they get a formal diagnosis.
That's kind of a good lead into diagnosing ADD and bipolar. Can you have ADD as an adult if you didn't have it as a kid?
You know, that's a very great question, Neil, and probably not. Probably the people who have ADD as adults are people who had ADD as kids. Now, let's talk for a minute about childhood ADD. Until a couple of years ago, until 20 years ago, the diagnosis of ADD was very poorly validated. So basically the criteria were various people's opinion about what ADD was. The issue of bipolar disorders is very well described, and pretty much everybody knows what it is. But ADD has been thought about, and until some people started to do validation studies, the criteria for diagnosing ADD were all over the place. It's only been in the last 10 or 15 years that people have tried to standardize that. And there haven't been any really good validation studies in adults. So what you want to look for if you're going to diagnose adult ADD is someone who clearly had it in childhood and continues to have persistent attentional difficulty. The problem is, again, there's a spectrum. With bipolar disorder, people are they're themselves and they're crazy. With ADD, there's a spectrum of how attentive people are naturally. And there are people who, by their nature, without ever having anything wrong with their brain, don't like to sit and pay attention to something for long periods of time. It's not their nature. And some of them are very high-functioning people. That's just not their kind of bag. And they aren't disordered in any way. Whereas ADD kids, at least the ones I see, really have something wrong with them. And I can often address the issue in adults and say, no, this is a person who really has trouble attending. But there is a dramatically increasing population of people coming into psychiatrist's office saying, I have trouble paying attention, and getting medicines for ADD when the real problem is they're bored, or the real problem is that they're doing a work that's not in their nature, and they're having trouble because of that. And the problem with the drugs used to treat ADD is they make everybody feel better and everybody pay attention better. So if you don't have the condition, in a sense, you're doing a little bit of cosmetic psychiatry. That is, making people feel better without actually getting them better.
Right. In the area of bipolar disorder, there's talk about lots of different types of bipolar. Bipolar 1, bipolar 2, 3, 4, 5, and 6 people are talking about. What's the significance of different subtypes in bipolar?
Well, the real classic bipolar disorder is where people have episodes where they're depressed, and then they have episodes where they're manic. And the mania part of it is that they're really quite sick. They have psychosis and gross disorganization of their behavior, and they're disordered when they're manic. And it's clear. Bipolar 2 patients have depressions, but their manias are very mild. We call it hypomania. And bipolar 2 was named that because the patients have a modest elevation in their mood, but actually they often function quite well during those times, and they enjoy them, and they don't get disordered and disrupted. Now, bipolar ones enjoy their manias too, but nobody else enjoys them. So it's a terrible problem for everybody else. And when they kind of get over the episode and see that they've bankrupted themselves or gotten themselves in terrible trouble, they are also upset. But during the period of mania, patients often really like it and don't want to get treated. And some patients will even go off their medicines to deliberately try to get a manic episode because they enjoy them so much. But bipolar type 2 patients often are quite functional during their hypomania, or even say their functioning is improved. And sometimes you'll see the people around them say, yeah, when he's up, he's really on. And so bipolar 2 is a description of a condition, probably the same illness, although we don't know that, but where the manias are much milder. The other subtypes include things that are sometimes called rapid cycling, where people go in and out with very short episodes of mania and of depression. We don't know if that is a different condition or the same. Then there are a group of people that only have depressions, but when you give them antidepressants, have mania symptoms. And we don't know if those people have bipolar disorder, but that again looks like a different population of people than have classic bipolar. So that's what all the subtypes are.
All right, so we got the subtypes. Bipolar 1 and 2, the most common. The 1s can get real high. The 2's not quite as high. What kind of workup do you suggest? Patient thinks that they might be having either one of these conditions. What kind of workup? How do we diagnose them? Do we order a brain scan? What should we be doing?
Well, at this point, although there are tantalizing and delicious studies that suggest that eventually we're going to have a diagnostic test, right now there's no diagnostic test for bipolar disorder or ADHD. The diagnosis is made by a clinical expert who's seen lots of cases and can distinguish the symptoms from other kinds of conditions.
How helpful is something like the Connors Performance Test? One of the tests that people walk around and say, well, I had that test for ADD, and darn, it says I've got it.
Yeah, again, what you're testing performance, and anything can impair that performance. Attentional distraction for any reason. So people on benzodiazepines, Valium and Klonopin, do poorly on that test. People who are extroverted and have very active minds do less well on that test than you would expect. So there's a lot of reasons to not do well on the test, and the diagnosis isn't made by the test. The really good psychologists will say that what these instruments do, where you take written tests, is quantify the clinical impression. So if you think the person has major depression and you do a Beck depression inventory and they get a number of 17 on it, then you can say, okay, this person got a 17 on their Beck, and then you give them medicine, it drops to a 8. You're able to track the improvement. But a Beck isn't better at diagnosing depression than a clinical examination. So the best exam is the best diagnosis is still from clinical examination for these conditions.
Now, is there some bias amongst clinicians to diagnose one of these disorders over the other?
Well, there's always fads in medicine, and so when something new comes along, like it's only been a few years since we realized that kids who have ADD often continue to have attentional difficulties as adults. So adult ADD is a new and exciting diagnosis, and there are companies that make medications that are used to treat ADD, and of course they want to market them and encourage people to use them. So there's a tendency for people to be enthusiastic about ADD. Bipolar disorder is something the patient doesn't often want to have, and the clinician often doesn't want to have to treat. But on the other hand, good clinicians really distinguish between these conditions very well. And in most patients, they're easy to tell apart if you're an expert, if you spend a lot of time examining people. The problem is they're not easy to tell apart if you're inexperienced and a layman and haven't examined lots of people. So there's all kinds of magazine articles about how to tell what you have. Unfortunately, the diagnosis really is best done in expert hands. And we're seeing now a rash of children who are put on stimulant drugs because they're naughty in school, and the counselor recommends they need some kind of treatment, and the pediatrician puts them on it, and they never get expert evaluation to see if it's an affective disorder or a problem in the home or a behavioral problem or a problem with extroversion, a problem with a person who's too smart or not smart enough to be in that class and therefore not able to attend because their mind wanders. There are all kinds of reasons kids have behavioral problems, but if you give kids stimulants, their attention will get better no matter what the problem is. And so it looks like you've helped something when you may not have.
What's the downside then, Glenn? What's the other side of that not helping?
Well, the issue with stimulants is that they do have side effects. They decrease weight in kids and maybe retard physical development some. And then there's Terry Robinson's work from University of Michigan looking at the toxicities of stimulants over time, and they do have considerable toxicities in animal models and in human models. So the drugs aren't without side effects and aren't without liabilities. It's just like any medicine. If it can change your brain for the good, it can change your brain for the bad. And so you want to...
Yeah, that's an important point. Medication has to be properly prescribed for the right disorder. You have to weigh the risk benefits as doctors with our patients, since they have to be the ultimate arbiter of what they are or aren't going to put into their bodies. We're going to come back after break and continue the discussion with Dr. Treisman, differences between bipolar disorder and ADD. And callers, the lines are open. We're happy to take calls on either of these diagnoses or other things in mental health. Dr. Treisman, good to have you with us. We'll be back to you right after the break.
Thanks, Neil.
Opinions, options, answers. Voice America Health and Wellness.
Stay mentally, physically, and emotionally fit with Younger Every Day. Hosted by Dr. Bob Payson. Broadcast every Friday at 10 a.m. Pacific Time, 1 p.m. Eastern Time on the Voice America Health and Wellness channel. Younger Every Day will offer you alternative solutions for a variety of health issues, all backed by clinical, scientific, and medical data. Dr. Payson and other expert guests will inform and inspire people of all ages to look and feel better. Younger Every Day. Think clear, feel strong, grow younger. With Dr. Bob Payson, right here on Voice America Health and Wellness.
Women, do you feel that you're too old to be active, too old to be beautiful, too old to have fun, or too old to be fabulous? Well, if that's what you think, then there's good news for you. You're wrong. Tune in to Voice America every Wednesday at 8 a.m. Pacific Standard Time for Aging Outside the Box. Fabulous Women Over 50 with Shirley Mitchell. Aging Outside the Box is a fabulous, fun program that gives you every reason to feel greater than you ever have. Host Shirley Mitchell and O.E. Cruiser Small will cover phenomenal topics such as women's issues, health, diet, exercise, nutrition, faith, travel, and many other concerns for women of all ages. Feel young, feel smart, and feel fabulous by tuning in to Aging Outside the Box. Fabulous Women Over 50 with Shirley Mitchell every Wednesday at 8 a.m. Pacific Standard Time, right here on VoiceAmerica.com.
Tired of life working out the exact same no matter how much you try to change it? It's time to get a new perspective. Perspectives, Alternatives for Living Life Better, with host Margie Sugarman, clears the cobwebs of confusion and offers practical solutions to life's issues. Broadcasting every Wednesday at 4 p.m. Pacific on the Voice America Health and Wellness channel, clinical social worker and psychotherapist Margie Sugarman is here so you can make the right physical, mental, emotional, and spiritual choices for your life. Right here on the Voice America Health and Wellness channel.
To perform at your maximum potential, you need to have all aspects of your life working properly. On Mind, Brain, and Body, Dr. Michael John Kell will bring you honest, open discussions concerning your physical, mental, and financial health. If you're ready to find purpose and meaning in your life, tune in to Mind, Brain, and Body every Friday at 8 a.m. Pacific. Mind, Brain, and Body on Voice America Health and Wellness. Radio dedicated to your health, wealth, wisdom, and purpose.
Step into a healthier you. Voice America Health and Wellness.
Welcome back to Psychiatry Ask the Expert. If you have a question or comment, dial toll-free at 1-866-369-3742. Now back to the show. Here's Dr. Kaye.
Welcome back to Psychiatry Ask the Expert. I'm Dr. Kaye, and we have Dr. Glenn Treisman from Johns Hopkins with us this evening. We're taking calls as usual. Glenn, I want to start by asking you, does the treatment for bipolar 1 disorder and the treatment for bipolar 2 disorder, is there a difference in how we treat these and approach these pharmacologically? And also, is treatment a lifelong commitment? Once you get started, are you stuck?
Well, I'll tell you the party line, the data, and my opinion in that order. Bipolar 1 disorder is often a severe and disabling disorder. The medications that are used to treat it involve really two classes of agents, drugs that both prevent depression and prevent mania, often called mood-stabilizing drugs, and drugs that prevent depression and are antidepressants. The best of those drugs in terms of characterization, and the thing we know the most about, is a drug called lithium, which is a naturally occurring salt. It's the ultimate complementary and alternative medicine because it's a totally natural product, and it's used in its natural form, and you just weigh it and give it to the patient. They get so many milligrams of it, and it's lithium salt. There are several different salts, but they're all natural products. That drug, if you get the right blood level, not only prevents manic episodes, but has significant antidepressant activity as well. So there's been a couple big meta-analyses over the years that show that patients on lithium are less likely to be depressed, kill themselves, attempt suicide than patients on other anti-manic agents. But some people don't tolerate lithium very well, and they do better on anticonvulsant mood stabilizers or even atypical neuroleptic mood stabilizers. And those drugs have varying degrees of antidepressant activity, but are all pretty good anti-manic agents. And pretty much people with bipolar 1, if they have the real thing, my recommendation to them is always to stay on medicine. And the reason for that is that even though they don't have symptoms between episodes, the real recovery from an episode in terms of recovering to true functional baseline is very long, often months, and maybe even a year. So people have an episode where they're sick for a month and a half, and then they're treated and their symptoms go away. They still may have residual difficulty functioning for months after that. And I like to keep those people well. Bipolar disorder probably has the highest rate of suicide of anything we see. Bipolar and major depression, both with very high rates of suicide, lifetime-long condition. And
what about bipolar 2? I mean, we have a lot of patients who come in. You pointed out earlier, their elevated mood states, their hypomanias aren't really getting them in trouble. They actually like them. They may talk a little fast, not sleep quite as much, be more productive, but not really impairing them. The depressions are what they always complain about. What kind of treatment are we going to be doing with them? Because that's a much more common presentation, I think.
I agree with you, Neil. These patients are a little harder to decide what to do about. I do want to say one thing. I think our field as a whole undertreats the depressive part of bipolar disorder and overtreats the mania part. And that's because, as a group, patients are much more of a problem when they're manic for us and for their spouses and for those society than they are when they're depressed, when they're mostly a problem for them rather than a problem for us. And I think we do have to be diligent in bipolar 1 disorder, try to treat the depressions as well as the manias. In bipolar 2, mostly what people complain about is the depressions. The problem is that having a prolonged depressive episode will often precipitate a hypomania, and having a hypomania will often precipitate a prolonged depression. So even in patients with bipolar 2, I try to minimize their episodes and eliminate them. Now, there's a lot of controversy right now about whether to give those patients antidepressants or whether to aggressively use mood stabilizers, and you and I actually were in a meeting about that together where we were discussing the issue of giving antidepressants to patients with bipolar type 2 as opposed to giving them aggressive mood stabilizers. I think most of us are now at the place where we really want to aggressively give mood stabilizers first, and then if we have to, add antidepressants. because of the possibility of giving people significant dysfunction with the medicines.
So that essentially in bipolar 2, there's a risk if we use antidepressants, especially without a mood stabilizer on board, that we might actually increase the rate of cycling or put gas on the fire, so to speak.
Yeah, and also people get kind of funny blends. They get these intermittent states of activated depression or agitated depression, and people call them mixed states. But mixed states are incredibly dysphoric for patients. I have quite a number of patients who have been sent to me over the years because they just can't tolerate any treatment. And when you look closely at them, they're mostly people who get these dysphoric mixed states. And when you give them antidepressant medicines, they get really miserable. They get kind of a activated depression where they want to kill themselves and can't stand it, can't sleep, have more energy but feel more miserable. And those mixed states are tough.
Glenn, it's Jay. Sometimes in these chronic illnesses, when you propose to a patient that they're going to be on medication for a lifetime, it's quite normal and natural to understand that they might come back and question, perhaps, can I do something with vitamins? Can I change my diet? How about if I do this exercise program to look for some kind of holistic or more natural approach? What's the consensus on anything there in terms of real efficacy in treating bipolar disorder?
Well, I alluded to a little prejudice of mine. When it works, and we know it works, it's no longer a complementary or alternative medicine. It's a medication because we know it works. So the problem with diets and the problem with vitamins and the problem with some of the other herbals that are around is none of them have been demonstrated to be nearly as effective as the medications for preventing the relapse. On the other hand, it's the patient's life. And so if people come to me and they're miserable from the side effects of their bipolar medicines and they haven't had an episode in a couple of years, I will say to them, all right, try this, and let's taper you off slowly over a period of time and see if you start to get sick. And I'll try to get their medicines down to a minimum amount of medication. In general, the literature says that, people are going to get sick sooner or later if you do that. But if somebody has an episode every 5 years and in between they're much more comfortable on lower doses of medicine, then you might decide that that's a reasonable risk-benefit for that patient along with them.
All right, let me switch gears with you, Glenn. Talk about some of the treatments in bipolar 1 and bipolar 2. How do you like to approach medications in ADD? Do you like to start with the big guns, the small guns, mixtures?
In ADD?
Yeah, in ADD. How do you like to start things?
It depends on how certain I am of the diagnosis. Now, another thing that we talked about is comorbidity a little bit. A lot of people with ADD also have depression. A lot of people with ADD also have other psychiatric comorbidities. And so sometimes you're going to start with medicines that will treat both. But if people have straightforward ADD in childhood, the drugs that have been best studied are stimulants, and then there are a number of agents that are antidepressants that also look like they help ADD. In adults, it's my experience that if they don't have comorbid depression at all, they really don't have an affect disorder or family history of affect disorder, they probably are going to end up wanting to be on stimulants and doing best on stimulants. But I will often try them on medications like Wellbutrin or a tricyclic antidepressant first to see if those drugs work for them because they have less reliability. Now, again, there's a range of the type of patient you see. If you see somebody who's really vulnerable to the reinforcing effects of stimulants, stimulants are addictive, and you can get addicted to them and actually get to the place where you abuse them. If I have a patient who's had difficulty with drug abuse in the past or with addictions to things in the past, usually I'll start those people on anti-ADHD antidepressants and come to stimulants only if I get stuck.
Okay,
there's a drug that...
I agree with that approach where I try to start frequently at the milder, not controlled, non-addicting drugs first and work my way up. But I run into this all the time. Basic, a parent comes in and says, I took my kid, they were having trouble in school, to their doctor. The doctor asked them a bunch of questions and diagnosed ADD. And as I was sitting there, I thought, my God, those are the exact things I had as a kid. So they go home and they try their child's stimulant medication. They love the way they feel. And then they come in to see me and they say, Dr. K, I know I have ADD because I took my child's medicine, even though I'm not supposed to do that, and it worked. So doesn't that prove that I've got ADD?
Yeah, well, again, I said earlier, these drugs make everybody feel better and give everybody better attention. But, you know, in the hands of a good psychiatrist, you know, if this person comes to you and you're going to see them regularly, you know, if I sent my sister to you, you know, you follow your patients closely, Neil. That's part of the reason we're friends. And, you know, if you wanted to give a person a trial of stimulants and you watch them closely, you would say to their husband or to their wife or to their friends, we're going to put them on this medicine. I want you to tell me if they're irritable or if they're difficult or if they're not telling us things about it because they like the medicine, but it's actually hurting them. And if you do that scrupulously, you really don't get into much trouble with stimulants.
I do mention irritability as essentially as a side effect, that sometimes stimulants make people irritable, and we certainly have seen that as super caffeine-like drugs. I also noticed some of my adults, especially on stimulants, develop somewhat of a flatness in terms of their emotional expression, some aloofness, some disconnectedness. What's that all about?
Probably dopamine depletion. In your brain, the neurotransmitter that gives you the biggest connection to life and the sort of that you get from something good is dopamine. And what stimulants do is enhance the release of dopamine to give you more attention. But then when you should be getting a boost of dopamine for being connected to something or for being interested in it or for being focused on it or for being emotionally connected to it, your dopamine is depleted a little bit. And so people do get a little bit of aloofness and a little bit of distance. They're always a little up, but they have trouble getting more up when they need to. And the other issue for stimulants is they're depressogenic. So some people actually develop frank depression on stimulants that they didn't have before. Drugs make some people quite depressed.
Is that kind of what people would call the crash from speed in the drug vernacular?
Yeah, to some extent, absolutely, and it looks very much like major depression. Now, most of those people get better fairly quickly when they're off the drug, but there are some people who have very persistent depressions and persistent psychoses.
Okay, we're going to be going to break. We're going to come back with Dr. Treisman and talk a little bit more about what happens if we treat the wrong disorder. Dr. K and Dr. Treisman on Psychiatry Ask the Expert.
Helping you make informed decisions for your life. This is Voice America Health and Wellness.
Hey, how you doing? Educational videos, top quality, right here.
You'll never hear anyone selling education on the street. But with free family learning programs, you can get the education you need. Call 1-877-FAMLIT1 for information on free learning programs. 1-877-FAMLIT1.
Check it out. Your GED right here, guaranteed, ma. Come on, check it out.
Free family learning programs from the National Center for Family Literacy. Brought to you by the National Center for Family Literacy and the Ad Council.
When you combine energy secrets from ancient China and the latest breakthroughs in medicinal science, you get power healing with Dr. Shah. Heard every Friday at 5 p.m. Pacific Time on Voice America Health and Wellness. Each week, Dr. Shah will bring you another step closer to the expanding world of body-space medicine. You will quickly learn and appreciate how power healing is a perfect alternative to hospitals and expensive drugs. Take a step beyond modern medicine every Friday at 5 p.m. Pacific Time with Dr. Shah on Power Healing, right here on Voice America Health and Wellness.
Growing Up in America explores the challenges, risks, benefits, and differences this generation of children face each day. Hosted by veteran pediatric emergency physician and father of 4, Dr. Charles Muzica, this show is for parents, teens, and children. It crosses each generation. By exploring the unique aspects of matriculation within this current generation, we hope to find answers and ways of optimizing this experience for today's generation. Growing Up in America with Dr. Charles Muzica broadcasts each Tuesday at at 2 p.m. Pacific, 5 p.m. Eastern on the Voice America Health and Wellness channel.
Do you know how health insurance is supposed to work and why some believe it's not working correctly? To find realities behind the myths, log on each Thursday at 1 o'clock Pacific Standard Time to Voice America Health and Wellness for Inside Health Insurance in America with Sharon Alt. Every show will peel back another layer of how health insurance has, could, and should work in America to benefit employers, employees, insured and uninsured. You will also hear from industry insiders and high-ranking government officials, so join us every Thursday at 1 o'clock Pacific Standard Time for Inside Health Insurance in America, right here on Voice America Health and Wellness.
Increase the quality of your life by decreasing the chances of disease and disability. Listen to Age Management Medicine in the 21st Century every Wednesday at 1 p.m. Pacific, 4 p.m. Eastern. On the show, host Dr. Harvey S. Bartnoff will discuss how to optimize your health span through hormone therapy, preventative medicine, proper nutrition, and more. Improve your vitality. Enjoy your life. Listen to Age Management Medicine in the 21st Century with Dr. Harvey S. Bartnoff every Wednesday at 1 p.m. Pacific and 4 p.m. Eastern, right here on Voice America Health and Wellness.
Opinions, options, answers. Voice America Health and Wellness.
Welcome back to Psychiatry Ask the Expert. If you have a question or comment, dial toll-free at 1-866-369-3742. Now back to the show. Here's Dr. K.
Welcome back to Psychiatry Ask the Expert on VoiceAmerica.com. Callers, the lines are open. We have Dr. Treisman as our guest tonight. And Jay, you had a question for Dr. Treisman.
Yes, I do. Glenn, last week we spent a lot of time talking about psychotherapy. We had an expert on cognitive behavioral therapy and talked about the role that therapy adds to psychopharmacology. What's the role, if any, for psychotherapy in the treatment of bipolar disorder or attention deficit disorder?
Well, it's a great question. The issue for psychotherapy is that the word means a lot of different things, just like saying drug means a lot of different things. I don't think most patients will take medication without supportive and directive psychotherapies that encourage them and educate them and help them. The other thing is that these episodes are severe and they are traumatizing and they do leave behind difficulties for patients. And the psychotherapy can be essential to trying to rehabilitate people to a functional life. So the psychotherapy is incredibly important in both conditions, and it's different in both conditions. But the idea that you can just have somebody put a nickel in the slot and get their lithium out and that you've treated them isn't true. Even with hypertension, even with diabetes, patients need a lot of support, a lot of encouragement, a lot of what you might call psychotherapy to be able to overcome their disorder. And we're learning more and more that behaviorists are useful in almost every chronic medical problem.
You know, in listening to your description of both of these illnesses, and I don't imagine it maybe too much with young children, but it sounds like both of these would lend themselves to substance abuse as a way of dealing with the disease. How often is there comorbid substance abuse?
Well, it's astronomically high with both conditions. These are people at very high risk for substance use. Both for bipolar patients and patients with ADD have a tendency to be comorbid substance users. And they're, let's look at the bipolar literature first. If you look at the bipolar literature, people who both abuse substances and have bipolar disorder are at much increased risk for suicide. They have much lower levels of functioning. They're much less likely to take their medicines. They have more episode of illness. They have more homelessness. They have more joblessness. They have fewer friends. They have less connections with family. So the substance abuse makes that condition much worse.
Yes, right. Understandably.
Glenn, we've got a caller on the line, Barbara from Connecticut. Welcome to Psychiatry Ask the Expert with Dr. Treisman as our guest. Can you hear us?
Yes, I can.
Hi,
Good
Barbara.
evening. Hi. Dr. Treisman, earlier in the hour, you mentioned that untreated bipolar over time will have the person deteriorate as they age.
Yeah, many people deteriorate as they age if they're untreated.
Is that, I'm trying to strike a fine line here. is obviously if they're not being treated, they're not going to be well.
Yeah,
or are you talking about
when they're younger, in between episodes, they often get well anyway, and look pretty good. As they get older, in between episodes, they don't get quite as well. And in fact, many people running around in the streets who we call chronic schizophrenics, when you actually look at them clinically closely, have bipolar disorder. And there's a reason you want to detect that, because if you can get them on the right medicines, they actually have a much better prognosis than if you put them on the medicines that's used just to treat schizophrenia.
Barbara, tell us a little bit more about the question here. Go ahead and elaborate for us a little bit.
Well, I was just wondering, is this actual brain deterioration? Is the illness propagating itself, so to speak?
Great question. We don't know the answer to that. Most of us who are in the field and have looked at the data really think that there is brain damage from these illnesses if they're not treated. But the interesting thing is that the brain is amazingly plastic. People who have a stroke and can't walk after the stroke, they don't regenerate brain. Those cells that die don't come back, but they can learn to use other cells so they can walk. And there's an amazing recovery in people with well-treated bipolar disorder, even though they've been chronically very sick for a long time. So we don't really know how irreparable the damage is, but I'll give you a kind of a tantalizing thing. People who have chronic affective disorders, either depression or bipolar disorder, are probably at increased risk for Alzheimer's disease. They probably have less neuronal reserve.
Well, let me do two things. One is, you and I were at this conference recently that you mentioned. There was actually some data that was presented that showed cell regeneration, cell growth with the use of lithium and proper treatment. That looked pretty exciting. That was presented by some folks from National Institute of Mental Health. So I want to point out that there's some evidence in that area. I want to ask our caller if we got her question answered or not.
Yes, you did. Thank you very much.
Well, thank you, Barbara, for calling in. I appreciate that.
Okay, bye-bye.
Bye-bye. What happens, Glenn, if we treat the wrong disorder? Somebody comes in and they really have bipolar disorder, but we make a mistake. We think they have attention deficit disorder because of the symptoms they've highlighted, and we put this person on stimulants when, wow, they really should have been on mood stabilizers. What happens? Is there harm done?
Yeah. The mistake you want to make is you want to treat people with ADHD with the medicines for bipolar disorder, since they won't get better, but they're not likely to be injured. Whereas if you give stimulants to patients with bipolar disorder, their bipolar disorder can be activated and they can have pretty severe episodes. So if you were really confused in the clinic about what was going on, what I would say is err on the side of treating bipolar first, especially if you think someone has both. Treat their bipolar disorder and then think about stimulants after they're really treated effectively for their bipolar illness. But but stimulant drugs and antidepressants can kindle manias and give people a more protracted course and a more difficult to treat course of bipolar illness.
Glenn, thanks a lot for being our guest tonight. Do you want to make any closing comments, because we're coming up on the end of the show?
Well, 1% of people have this condition in terms of bipolar disorder, and ADHD is a very common disorder as well. And what we need is to advocate for better psychiatric services for everybody. We need to try and get out there and demand that experts are available to our children and to our poor and vulnerable people who really benefit from treatment of both of these conditions, and so that people will have better quality of life and be more productive. I think the cost of mental health treatment is trivial compared to the benefit, but right now we're in the time when people don't want to pay for treatment, and people are diminishing the availability of treatment, especially to the most vulnerable people. And I want to encourage people to get out and advocate for better treatment.
Glenn, I want to thank you for being our guest tonight. Very informative show. Boy, the time really does fly with a good expert. To our listeners, again, make sure you're properly diagnosed. Don't try diagnosing yourself. Access good experts. All problems with attention are not ADD. Attention is simply a symptom, and it's a symptom of anxiety and mood and maybe even ADD or bipolar disorder, but not everybody with problems with attention has ADD. if you're on medication, take it the way that it's prescribed. For both of these disorders, ADD and bipolar disorder, medication and therapy, the combined approach is the best. I do encourage people to bring family members in because we can get better history and some extra observing if we get the whole family involved. Good diet, good exercise, avoiding drugs and alcohol, also very important. And as usual, if you do visit websites, go to the good ones. Go to the National Alliance of the Mentally Ill.org, the ADAA.org, things like that. I want to thank the listeners for participating and tuning in tonight. Next week we're going to be discussing schizophrenia. Our guest will be Dr. Ranga Ram from the state of Delaware, former director of mental health for the state. And in the intervening week, I hope everybody has a safe, healthy, and happy week. Dr. Kaye and Jay saying, thanks for listening to Psychiatry Ask the Expert.
Thanks for inviting me, Neil.
Thank you, Glenn.
Thank you for listening to Psychiatry Ask the Expert. To learn more about Dr. Kaye, visit courtpsychiatrist.com. Tune in next Tuesday for another hour of Psychiatry Ask the Expert with Dr. Neil Kaye.